Hi, everyone. Good afternoon. I know everyone's had a really lovely lunch, and I hope this sets us up for a really creative discussion this afternoon. My name's Prasida Janakram, and I'm a family doctor at the University of Toronto Department of Family and Community Medicine. I'm the program director for global health education within our department and feel that very much connected to the topics we're going to be discussing today. I want to take a moment to do a special thanks to Dr. Tanini and Dr. Natalie, who are our co-chairs for this session this afternoon. They have been working tirelessly to make this entire PMAC experience for all of us so incredibly rich and engaging. So with that, and for the very first PMAC conference that I've had the chance to participate in, I'm delighted to get us started today. So, when I spoke with Tanini about what she'd like me to reflect on, she said, Prasida, I'd really love for you to share a Canadian perspective on health equity, on cultural safety, and how we're training health professionals in this space to work compassionately with structurally marginalized populations. She said, it would be wonderful if you could reflect on how care is being delivered in your setting and who delivers it and what might need to change. And let's consider how interprofessional collaboration and training with a lens to specifically focus on social and structural determinants of health can be considered. When I think about the world of family medicine and primary care, I think about the world that I live and work in every day. And I think about each of you. Maybe you're family doctors, maybe you're clinicians in other aspects of primary care and public health. Maybe you're patients and users of the system. Maybe you're economists and policy analysts and policy makers. Maybe you're researchers and scholars, because we need everyone. When I think about family medicine, I think about the mom who brings in her little baby, the young man who walks into my clinic for the very first time from a war-torn country, the elders in my practice, with wisdom and age, and also struggles of isolation. The newborn, the fathers and sons, the mom with postpartum depression, the teenager facing anxiety, the clinicians struggling to provide clinical care under strain, and those of us who believe that there is a fundamental way forward through education and interprofessional training. Family medicine and primary care is centered in the 5 C's. We're person-centered. We are first contact and gatekeepers to the healthcare system. We have continuity from basically cradle to grave. We offer comprehensive, high-quality primary care with an understanding that we will be comprehensive and offer coordinated service and community-informed and community-based care. These are our core values. These are the essential drivers of our work. When I think about the SDGs, and SDG 3 in particular, I think about how we make this work within the PHC approach. Multi-sectoral policy and action, empowered people and communities, and primary care and essential public health functions at the core of integrated health service. Where does family medicine fit in? Family medicine is our enabler, driving us towards strong and robust, high-quality primary care in service of a more equitable, compassionate, and community-based health system. We are also playing a critical role in interprofessional leadership of community-responsive, team-based care. And in our setting in Canada, we have 4 principles of family medicine that we sort of live by, I would say. We are skilled clinicians, we are a resource to a defined practice population, and we are centered by our patient-physician relationship, and we are informed by the communities in which we live and serve. And because of that, we have a capacity to play a greater role in the health system. Now, family medicine is the green circle in the middle, but we live within a PHC-oriented approach to systems and national policies and global programs. No matter the size of our green circle, whether we're a large green circle in some health systems because family medicine is well developed and expansive, or whether we're a small green circle in parts of the world where family medicine is emerging, pioneering, and paving the way forward. Regardless, we are developing access to care for the most vulnerable, addressing social and structural determinants of health, and we're committed to being accountable to comprehensive, continuous, coordinated quality care. So how do we deliver on the PHC approach? Primary health care is where the battle for human health is won or lost. Dr. Danielle Martin, the chair of our department, said this a couple of years ago, and it means the world to us. We could work in silos. Family doctors could work in practices by themselves, pharmacists could practice in pharmacies, social workers, mental health workers could each focus in their individual areas of specialty. But if we really want to make a difference going forward, we need to train together, and we need to train for a culture of we and us, rooted in equity, focusing on compassion, collaborative care, and rooted in cultural humility. So when Tanini mentioned today, how can we reimagine? Our team reimagined looks very much like this in Canada. This is what we're aspiring for. Teams where perhaps we have nurses, physicians, nurse practitioners, peer navigators, social workers, shared care, mental health, all working in a coordinated fashion. And this is increasingly the movement that we are headed in. Now, there are many ways that we can put people together and expect them to work as a team. But we know that there are core competencies, and there are many different frameworks for this that will look and feel different no matter where we work and practice in the world, and contextualize to the context. But certainly, this is one example that's working for us in the Toronto area, one where we emphasize shared decision-making, interprofessional values and ethics, communication, conflict resolution, reflection, and role clarification. And if we're going to train together, we want to train where care is brought together by all the team members for robust and high-quality service, where education means we're learning with and from each other, and where leadership means that every voice on the team is valued. Every diverse perspective matters. So our team reimagined needs to include our patient partners and the voices of every community member that we know need to be reflected in the decision-making process. We need to start representing empowered communities and people more effectively and with voices amplified. So how do we build a culture of we and us? In our setting in Toronto, our Vice Dean of Clinical Affairs and Professional Values and I, and several other faculty, are working across our departments to integrate some of these key principles into the training of interprofessional teams. We're drawing on the COIN model of privilege and critical allyship, developed by Dr. Stephanie Nixon, a thought leader in this space, really referring to the COIN as a system of inequity, where there's privilege and there's oppression, and we will all find ourselves on one side of the coin or the other, depending on the situation and the issue. We didn't necessarily ask to be there. We weren't necessarily given a choice. We teach about power and positionality, the wheel of power and privilege. We think about the fact that there's power at the center of the circle, and there may be less power on the margins. Every single one of us can find ourselves on this circle. Every single one of us will waver in terms of where we land, depending on the issue. We're teaching this to all our faculty, to all our learners, increasingly with more momentum, because we appreciate that if we can all understand each other and see each other more clearly, perhaps we'll have more empathy for one another, and we'll understand and work more closely with our patients. We're teaching about intersectionality, the fact that all of these dimensions of power and privilege intersect with one another. And that defines who we each are, our lived experience, and the lived experience of our patients. This is how we're training an interprofessional environment towards cultural humility. An ongoing process of self-reflection, awareness of our biases, our values, and our perspectives, validation of our strengths and our capacity for resilience. Canada is actually a country of newcomers, but the First Nations people of Canada, our Indigenous people of Canada, have actually experienced the most significant of intergenerational trauma, and we are going through an ongoing exercise of truth and reconciliation. Our Indigenous people teach us about cultural humility, and we have so much to learn. This was developed as a framework presented by the First Nations Health Authority of our Indigenous people in British Columbia, our westernmost province in Canada. They're teaching us that it starts with me. It starts with the patient, it starts with the person. That the past is still with us, that heritage and history matter when we think about the whole person and the care of a person, their family, and their community. That change leadership means you can run, or in this case, lead the run. And many of our community leaders are actually the ones doing that incredible leadership work, and we can follow and walk as allies alongside them. They're teaching us that we have moved on the continuum from cultural awareness to cultural sensitivity to cultural competency and safety, and now cultural humility. Training in family medicine and interprofessional workforce with compassion means that we're acknowledging that we can't do this work alone. Just 2 days ago at the side meeting, we engaged in a rich discussion about the fact that there are two very different populations, migrants and the aging, that Thailand is working to serve more effectively. Two completely different populations with diverse needs, one healthcare system. Later that afternoon, we heard from faculty and learners about the challenges of working with complex care for patients in a system where they're not sure they feel they have all the tools. And there is a risk for moral injury and for a sense of disempowerment and a lack of agency. But it doesn't have to be that way, especially when we train for a culture of us. And we bring together a team that adjusts to the landscape, that identifies that we are reflecting demographics that are changing, and understanding power, privilege, and positionality strengthens our health equity approach when we build a workforce that understands the culture of us. This is how we come down with those barriers to health access. This is how we bring those barriers down. There are many health barriers and many more that all of our patients across the life course will face. And as an interprofessional team, we have the capacity to address it. We need to ensure that we're bringing together the voices of our community. Our community is a collectively wise and remarkable group of knowledge keepers who form a global community of champions with rich expertise and lived experience. And actually, our colleagues here in Thailand are doing this better than so many others. We have so much to learn. I am blown away by the examples of how civic society and civil society are integrated into every layer of the models of care in the systems here, in the advocacy, in the outreach, in the volunteerism, in the policy and action change. So we're listening. And that's an incredibly important skill. And interprofessionalism and family medicine and primary care can be at the heart of that. From our department, we've had the pleasure of listening with ears wide open to a global community. Through the Bezroor Center, founded by Dr. Catherine Rouleau, who's sitting here in the audience today, the Global Health Center for Family Medicine at the College of Family Physicians, our programs to advance women in excellence in family medicine with an understanding that not only are the demographics of our patients changing, but the demographics of our providers are changing too. In family medicine, we know that over 50% of providers will soon be women across the globe. And there are young women in family medicine and primary care who are being tapped into leadership opportunities across the country, across the globe. And how can we empower and uplift their skills? The Toronto International Program for Strengthening Family Medicine and Primary Care has been bringing together family medicine and primary care professionals in the spirit of taking on the challenges of global context with solidarity and sharing and reciprocity. And we've been learning from our partners in Ethiopia. Ethiopia, where we've partnered for many, many years, is pioneering family medicine under very challenging circumstances. And in so doing, they've identified the importance of policy and advocacy and dialogue for their specialty. And we've brought together colleagues through the Starfield Summit, Toronto 2025. This year, a landmark year, a year of bringing together family medicine and PHC experts in the spirit of understanding how family medicine can drive the PHC system approach forward. With all of these activities, we are not working in silos and we are not working in isolation. We're asking for a highly interactive collective visioning. And we are listening and we are evolving. We appreciate that the future workforce of tomorrow in the delivery of family medicine and robust, high-quality primary care lies in team-based care in our environment. And we're asking for transformation with the support of people as advocates, as co-designers of their system, and as decision makers in the health and delivery of service. And so I'm going to ask us to take a moment. And I'm going to ask us to think about what it means if we want to reimagine the future. If we're reimagining a future, I'd like us to think about this quote. If I could choose to live in any time in history, I would choose tomorrow. Informed and co-designed by a wise team of many voices, patient voices, community voices, your voices. Honoring the diversity of the knowledge keepers in our community, of all ages, our children, our adolescents, our aging, our palliative. I'll ask you to reflect on what reality do we want to be true. For the people we work with, our teams, our reimagined teams, our allies. For the people we care for, our patients, our persons, our community. What will success look like? And what will change if we are successful? So when we reimagine, what reality do we want to be true? If primary health care is where the battle for human health is won or lost, then I'll ask you to ask yourself, what are we fighting for? We are fighting for the health and well-being of all our patients and all of the communities in which they live and where we serve. And we're fighting for a culture of we and us. Thank you. With deep gratitude, I look forward to the conversations that we continue from here.
Thank you very much, Dr. Pasida, for your thoughtful and grounding keynote speech. This set the stage for our discussion today. Good afternoon, everyone. I'm Dr. Isarang Nuchprayun from the Wishing Well Foundation, Bangkok, Thailand. I'm honored to be your moderator for this afternoon's session. The parallel session 1.3 explored the theme that's deeply human and increasingly urgent: the role of the family, community, and supportive environment amidst profound demographic shift. Crossing the aging society, smaller household, and the migration and the changing caregiver's role, we are being challenged to rethink and then not only how care is delivered, but who cares for them, who really involved in providing care. Today's panel discussion brought together the perspective of the governance, mental health, palliative care, and environmental design and the digital health, offering us a rare opportunity to connect the systems thinking with the lived experience. So we will now have a brief presentation by our panelists, each speaking for around 10 minutes. And then I encourage you to listen, not only for solutions, but also for the shared value across the discipline. Okay, now our first speaker is Dr. Dinesh Arora from the Asian Development Bank, who will share with us the regional perspective on integrated governance and the early childhood development. Dr. Arora.
Thank you for a wonderful keynote address, and it's a music to the ears, especially in this divided world, in this monopolistic world which we are moving towards. So thank you for bringing the perspective of family medicine on this. But let's get one step before this. Family, right? Invisible, informal, which helps us deliver so many things which we don't even realize. And how is it coping up when we feel the strains of urbanization, migration, the strains of lower fertility indicators as we move forward, the nuclear size of the families, the aging society? How does it all cope with this? And where is family? Where is the default woman here who's been supposed to take up the whole of the work of the family? And this is where I would like to speak on a share of a perspective from India, a state in India, Meghalaya, which is a northeastern state. So we'll talk about here, should we allow this family to just bear this stress or get on the governance mechanism to support this family for rearing a child and perhaps old age? I still remember the quote when we used to say that it takes a village to raise a child. Where is the village now? And where is that child to be raised in an urban area, conglomeration, in any part of the world, and specifically in Asia Pacific? So I'll start with this, and for a family, the whole process becomes actually a life cycle approach from early childhood. Now, it's already written there, but I must say that first 3 years form 75 to 80% of your brain. And this is not automatic. This requires stimulation. This requires something technically called the serve and return phenomena, where a mother or a caregiver talks to the child, responds to the child, and those neuronal cycles are built on. Then comes the age of adolescence, where suddenly we have a physical, cognitive, and psychosocial growth. The emotional intelligence component builds over. Adults, which actually require, which is the most productive age and require accessibility and affordability of care. And then as we move towards the ensuing aging as a process of dignity and comfort and not just a decline. So the whole human development lens comes through a life cycle approach. And here comes the important role of how do we deliver this. So when I talk about early childhood development, just 2 slides on the background of this, why early childhood development. If you can see the dark shades here are the periods of criticality within the developmental phase. And if we miss out on those, these are irreversible. You can talk about linear growth, which is the most easiest to measure when we talk about stunting. But how much do we talk about seeing, hearing, receptive language, expressive, higher cognitive functions, or socio-emotional development? Hardly we measure them in our public health life, other than stunting, wasting, and perhaps underweight, which is the most common being used. So a child which is not born stunted becomes stunted in the first 3 years because of we not being aware how to reach a child unless we teach those scientific techniques to everyone, not only the family, but the whole community. And this is where governance is required. Governance for making public health truly democratic right from the birth of a child. On the right side are, which shows, if you can see from here, I hope it works. Otherwise, I think I should try to use this one. If you see here, yeah, that's much better. If you see from here, these are a normal trajectory, having good protective factors like a good nurturing care, good family, good caregiving, good nutrition, good economic sense of security. And this is a line on the right side, which has a below potential factors. Now, if you do an intervention here, it actually has a multiplying effect in the early childhood. But if you do any intervention later, it requires much more effort and much less results. So this is where the Heckman curve says that $1 can lead to $15 to $17 of return on an early childhood. And imagine what we do. We are a bank, an Asian Development Bank, and we were typically an infrastructure bank. Most countries want to set up roads, railways, trains, but not on social sector, which is the multiplier sector for human capital development. Things are changing. Things need to change much more here. And this is what the WHO framework, which came out very recently, this is about 2019 or 18, just before COVID. It took us so many years to define what should be an early childhood care. Traditionally, we have been talking about healthcare through a family doctor, through a family health worker, through a caregiver. But it has 4 more components. Nutrition. It talks about responsive caregiving. It talks about how do you renew the confidence of a woman or a caregiver who is giving, and perhaps also the sense of security, which all 4 factors come in. So I've given the practical examples along with it. Responsive caregiving is paid parental leave, affordable child care services, security and safety, especially the woman's time poverty, which I'll come to the next slide. Universal access to good health care, and of course, the health and nutrition being important components here. I would like each one of us to ponder here and think about it. When did women become the primary caregivers, and why did they by default become that? So if you see, as compared to men, women shoulder much more responsibilities. And this is not only in childcare, not only in days, not only in hours, but also perhaps in taking care of elders at home and taking care of other utilities. I'm talking especially in the context of Asia and Pacific, where mother is still expected to cook the food, the 3 meals, plus take care of the child, take care of the adults, and then, if possible, work also. And this is where this has led to, in certain parts of Asia Pacific, a very low fertility rate, that paradox coming up here. And this was a Times survey done in India in 2018-19, which talked about that women actually spend 20% of their day in unpaid activities taking care of food, adults, and other household chores, as compared to just 3% by men. So the unpaid caregiving comprises only 3% time used by women, less than 1% by men, and is not exclusively for childcare. So where does an early childhood get those stimulation, what I was talking about? The care even by a mother is custodial. When she is working in a house, a child cries, she goes, feeds milk, comes back, works. When a child poos, again goes, cleans it, and does her work there. This is more of a custodial care than a nurturing care. And this is where the whole paradigm of family comes. So I'll take you to here from an example in Meghalaya. It's a northeastern state, as I mentioned, in India. It's a hilly, tribal state. 85% population is tribal. 75% of the population is Christian. This has matrilineal society, and still the stunting is among one of the highest in the country. 46.5% as compared to India's 35.5%. The point here I wanted to make is that it's something beyond more than what we need to do for a family and a community to come together and being part of the governance. So what I'm showing here is a model which we are trying to implement in Meghalaya with government of Meghalaya, with 5 departments on the left side involved primarily, and then coming up with measures at community, at home, and at the center. Center means at the institution, the daycare center I am talking here about. But it's important that we take care of all these 3 parameters which we are discussing in each project, in each public health field when we talk about. So if you see on the upper side is a daycare center which was established, and then the daycare center which are being established under the project. And this is not just buildings, it's building transformation. It's a public health angle to all those children who come there as part of nurturing care framework. We are talking here about increasing the daycare services from normally 10 a.m. to 2 p.m. to 8 a.m. to 3 p.m. so that mothers could take up meaningful employment as she work, and they can drop the child. Why only mother? Parents can drop the child, father can drop the child and pick up on their way back when they're done their work. So that's one of them. So is it a blipper for me to round up very fast? Okay, and then this is one of the daycare centers which are going to be a joyful learning center. Next, community barefoot pediatricians, I call them. They're the community health care workers. We have seen that through a normal health trained worker, you can miss on developmental milestones which are getting delayed, and then they become disabilities. The rate is as high as 10 to 15%. If you train the community mother and the frontline worker on identifying different milestones, it can actually help us identifying disabilities and mitigating with them. So there's a tool called Growth Monitoring Control Tool, GMCD tool, which has been validated by WHO and is used only in 2 or 3 countries in a public health way, where all children in the village will be used for. One mother exercise is giving hot cooked meals to mother and the child when they come to daycare center, rather than just providing them with ration, which is done take-home ration, because we do not know who is eating that at home, but how mothers eat when we are doing there. And of course, with faith-based institutions like pastorals, like the pastors there, we actually come up with a nutrition survey anthropometrically, and then see what diet diversity comes through. As I mentioned, we are doing a very rigorous impact evaluation with Johns Hopkins University, and realized that stunting is not when they are born, but stunting starts when the complementary feeding starts, say about 10 months after they have been born. After 6 months, and actually the complementing starts, and 10 months later, we realize that they are stunted. So this is where it gets into a multiplier effect. And of course, self-help groups within the community, using them as volunteers to train them and then use them as for nurturing care framework. Many of mothers are not aware of how to do breastfeeding, the different practices, the timing, and how the stimulation to be done. And that's what is being taught through a partnership with one of the Indian Institute of Technology. And of course, shaping young adults, we are putting up a young adults as ECD fellows, additional hands at the daycare center, making them part of care economy, training them, certifying them, and then they can actually do their own care economy entrepreneurship as they move forward. And to anchor all this, coming up with the Center for Developing Child Meghalaya, which is going to do a anchoring of all the reforms which are happening in the early childhood. The idea here is to take the public health to community, to the village, to the mother, use a whole of government approach rather than siloed approach and putting them into practice. Now, this has been cited as one of the best practices. This was recently presented to the Honorable Prime Minister of the country in India. And we see this to be scaled up at the national level for about 1.3 billion population as India has today. One couple of slides on similar model for long-term care, and just wanted to give you one example from Mongolia, where we are implementing community hubs near the residential. They are the one point of contact, and they provide referral care along the hospitals. And in PRC, Yaiching City, which involves at the 3 level, one at the family, second at the community, and third at the healthcare, through public-private partnership, where government sets the regulation, standards, and quality requirement, and the private sector pitches in. So huge scope to work together for the community, for the family, and for the institutions to take care of early childhood development as we move forward. Thank you.
Thank you very much, Dr. Dinesh, for your excellent presentation, inspiring talk. Next, we'll introduce Dr. Katie Malbon. She's a consultant pediatrician at the NHS, leads for the acute CYP Mental Health UK. She will share with us on the system-based approach for the adolescent mental health. Katie.
Thank you very much, and thank you so much for inviting me to speak. It's an absolute honour to be here. So I'm going to talk to you about how we've had to adapt in the UK to an increase with poor mental health for young people. So I'll start off by telling you a little bit about me. So I am a general paediatrician, and I trained in England, but I also had some training in the United States in adolescent medicine. But I currently lead in paediatric and adolescent rheumatology, adolescent gynecology, mental health, and safeguarding. But the common theme throughout all of these different specialties is mental health. And what I've learned over time is that the only way to approach these patients, and all paediatric patients, is with this concept of parity of esteem. So that is giving equal measure to both physical health and mental health. In my mind, you can't have one without the other. A child with a chronic physical condition, there's undoubtedly that has impact on their mental health. And a child with mental health crisis then will have physical symptoms. So I work at St Mary's Hospital, which is part of the Imperial College NHS Healthcare Trust. So we're affiliated with Imperial College, based in London. And you may know it for the gentleman pictured in this slide, who's Alexander Fleming, who was responsible for the discovery of penicillin. It's a large hospital. We have between 1 million and 1.3 patients, based in the sort of northwest London sector of London. And so why do we need change? So really over the last 10 years, we've seen a real increase in poor mental health in young people presenting to hospital, but particularly after the pandemic. So now we see about 1 in 5 children and young people aged 8 to 25 years with a probable mental disorder. And we've also seen a change in what they present with. So they're presenting with self-harm, with suicidal ideation or suicide attempt. But we've seen a real rise in children and young people, particularly adolescents, presenting with dysregulated behaviour. And we think they're just sort of tipping over, they're just not able to manage all the pressures that are happening during the adolescent years. So at any one time on our ward, 1/4 of the patients will be admitted due to a mental health problem. And you can imagine that means we have to adapt. So nurses and doctors trained in mainly physical health. We have a little bit of mental health training, but nothing that will prepare us for the types of presentations that we're seeing. And as an adolescent specialist, I'm often asked, why are we seeing this so much now? And there isn't really one answer to that. I think that adolescents have always had a fairly turbulent time. There's a lot going on during these years. Their brains are still developing. The parietal lobe, which is responsible for processing information, is not fully formed. And yet they're getting so much information to have to process. They've got smartphones. They've got more access to all this information. We know that lockdown affected many adolescents in many different ways, depending on actually where they were during their developmental process. And we're living in a world with many problems, which they are exposed to. So I think it's all of that together which is just tipping many of these adolescents into poor mental health. And so traditionally, we have, as I said, treated the physical health needs of children. And we work in a system, I'm very fortunate in the UK that we have a national health service, free healthcare for everybody. It is fantastic. But it's also a very traditional system, which has structures and systems that have been there for years. And it's very hard to push against those structures that are already in place. And this accounts for our environment as well. We have paediatric wards where we have newborn babies next to 16, 17-year-olds. And, we have very little privacy on our wards. And you can imagine if you have an adolescent with dysregulated behavior, that can be really hard to manage. It's incredibly difficult for our staff, for our nursing staff particularly, who are just not used to having to look after really, they can be quite violent patients, and having to work out how they communicate with these patients who really, don't want to be there, don't want to be alive. It's really, really challenging. And so there's a huge moral injury on the staff, and that leads to really poor morale. So we were in this situation where everybody was just suffering with how to manage this new demographic on our ward. How could we do a better job? So what did we do? Well, we were very fortunate that the government has actually given some money to allow us to make some changes. They saw the need. They could see the numbers going up of young people being admitted to our physical health hospitals, and actually the length of stay of many of these patients is huge. We can have patients on the ward for years at a time, whereas we're used to, our paediatric wards are used to very high turnover of patients. So we were given some money, and this money that I received, along with many other colleagues, was really for North West London. And we have 5 acute hospitals within North West London. Each of these hospitals has a paediatric emergency department. So with this money, we then had to work out where we could really make a difference, how we could create this changing culture to accommodate these young people. So we divided it into sort of 3 main work streams. The first one being leadership. So each of those 5 acute hospital trusts has an acute lead for children and young people's mental health. So I'm at St Mary's Hospital, and I have 4 other colleagues at the other trusts. The second work stream is about networking. So there is a lot of resource available for young people with poor mental health, but it's all very fragmented. And it's spread over various parts of London. And no one was seemingly talking to each other. And we just didn't know what was available. There are also lots of charities that offer really good resources for young people with poor mental health. So it was about understanding our landscape. Also, understanding the language that different professionals use in different areas of work. And we realized there was a lot of misunderstanding of language and about how different teams work. So from the very beginning, we needed to sort of sort that out and work out what was what and who was who. And then a big component of this work is education. So really understanding how we can better care for these young people, how we can communicate better what it is that they're struggling with, and how we can sort of move them through the acute hospitals to actually better places of care. So first of all, we asked the staff, what training did they need? How could we give it to them in the best way possible? You know, everybody's so busy working. This is something extra. And with poor morale already on the wards, it was quite difficult to work out, how we could do this effectively. So asking the people was what we did. And everybody wanted it across the board. But then, we were being told this needed to fit in with our working life. It can't be too long. It needs to be pragmatic. And it needs to be for everyone. So it needs to not just be the doctors and nurses, it needs to be the administrative staff, the person sitting at the front desk when the families come through the door. They need to understand how they manage these patients, the security staff. So it needed to be really comprehensive. So we made it tier 1 and tier 2 training. Tier 1 training we offer for every member of staff and any new member of staff coming to the hospitals. And actually, this is an online sort of module, and it's a company called We Can Talk, and it's a brilliant sort of session around sort of the first level of training around mental health. So everybody in the trust does that. And that's not just paediatrics, actually, that runs all the way through all life stages. And then tier 2 is something we're really sort of proud of developing. This is around simulation training. So we started it at St Mary's Hospital. It is for everybody. And we have groups of a maximum of 12 people in a group. And we have an actor, and we go through lots of different mental health scenarios. It's facilitated by myself and members of the psychiatry team. We put these sessions on when everybody can attend, so during the working day. And so far, we've actually done a few more after this, but around 30 sessions. We've trained at St Mary's over 300 people, as I said there, from all disciplines, and we adapt them to who is attending. So I had an amazing session a couple of weeks ago where no one wanted to sort of put themselves forward to be the doctor or the nurse or the member of staff actually talking to the patient. And so we said, okay, let's just get everybody involved. And we had 10 people in the group, and we gave everyone a role, and they role played how it would appear on the ward. So we had a member of security, we had a nurse, we had the front desk administrative member of staff, and actually it was fantastic. They really, really got into it and got so much from it. And now what we've done is the train the trainer model. So my other acute leads from the 4 other hospitals have come along to the training I do at St Mary's, and they've taken that back to their hospitals. So we're training a huge number of people. And the feedback has been really good from this. So to conclude, we can make change. However long the system has been there, it is possible. By just gently nudging along, change can be made, and it's so important that we really, really need to adapt to these new situations. So I couldn't have done this alone, of course. I have a fantastic team. So these are my other colleagues at the other 4 hospitals, one of my administrators and one of the other sort of North West London sector leads, who are just amazing colleagues to work with. So thank you very much for listening.
Thank you very much, Dr. Katie, for your inspiration on the mental health solution. Next, I'll be sharing with you on the compassionate approach to the palliative care for children. And I was a pediatric oncologist by training. And then I have, with a long career, I have moved from treating children with cancer to taking care of children with cancer who are incurable. And what is known, the wording known today is palliative care. But what is actually palliative care? You imagine this picture where children are dying peacefully in the hospital, or this one, where these are similar situation of incurable cancer. Now, these are actually part of the palliative care. It started, when my career was started with the newly diagnosed childhood cancer. We give them standard therapy, which is the best therapy possible. It results in a cure for over 55% in Thailand, maybe a little bit greater in the Western world. But with limited resource, 45% will eventually relapse or recurrent. And what do we do? Usually, we give them the second treatment, which results in another relapse. Because the best outcome is the first therapy. Then if they relapse, we give them again. Some of them said this is too much. They abandoned treatment and went away seeking herbal therapy, for example, and die in suffering. If they continue on, we give them the third treatment, and eventually they die in disappointment. Or they may die with the complications of the therapy. In rare case, the child said no more, and the family have to agree. And they stop treatment, lived for a few minutes, few weeks, and then died, what we call end-of-life care. But there's other ways of doing this, which is called palliative care, whereby children can live and enjoy life for some time. And eventually they die, but with satisfaction. So the way to introduce palliative care is actually not easy. If you ask the parents, what should we do when the cancer is relapsed? Most parents will say, please give my child another chance. But nobody really asked the child what they wanted. After some time, I worked for 15 years, I have a question. Are we doing the right thing, keep giving treatment, and then they die in disappointment? So now, one child says to me, one mother said to me, well, if I have known this, I would have taken my child to the beach. So then that inspired me to ask the children, after some 15 years of working, what do children really want? And I realized they never want treatment from the first day. Because all children want is whether I can get ice cream today. Can I go play with my childhood friend? So the genius we have discovered, instead of trying to approach this directly, we ask them, how about what you like to do? What's your wish? And they will all say to me, well, I want to go to the beach, right? Actually, the beach is very easy. It's only 1 hour from here. But the fact is, mom never asked. And if the child says, I want to go to the beach, she will never go. Right? So I said, wow, we can do this for you. How about you go to the beach first, then come back and talk to me about the treatment. And we empowered them hard enough. They said, okay, doctor, we go to the beach. And then they come back. They have seen the child was so happy. And the mom was happy. And I was happy. And then now I asked the mother, I asked the child, what else do you want to do? Mom said, how about the therapy, doc? The child said, I want to go to the mountain. I said, well, you go to the mountain first, then come back and we'll talk about the treatment. So mom take him to the mountain. The child was happy, mom was happy, I was happy. And then I asked her, what else do you want to do? So they said, one thing was done, 2 things was done, 3 things was done. I can't think of anything else. Then by this time, the mother says, okay, doc, whatever happens. They're no longer interested in the treatment. Because everyone wants treatment because they hope the child will be cured. And then we will do all of these things. But it never happens, right? Because if they fail treatment the first time, they're never cured. So this is the way, of introducing is a fulfilling wish for children who has relapsed cancer. You see, the child endure treatment for some time for hope of cure. If they are cured, then everybody's happy. But that half of them is not cured. So therefore, if the children have a choice, they will choose no treatment. They will choose to be doing something which is meaningful for them. But if we are in Bangkok, going to the beach is easy. But if I live in the northeast Thailand, going to the beach, the mom have never been to the beach, right, themselves. They said, good idea, but I don't have money, doc. I have to work hard first. Then I save enough, go take my child to the beach. I said, no, you don't need to do that. I'll ask people for some money, take him to the beach for free. Then the mother and child will be happy, right? Someone else can. So one child, this all started like 15 years ago, because a child says, I want to go to see the panda in the northeast Thailand. The panda was from China, of course, but they keep it in Chiang Mai, so that we take the child to Chiang Mai. And he saw this in the TV, but he has never been there. And I haven't been there either, because I was trained in the United States. I came back to Thailand, I didn't know where the panda was, right? But I need not to know, because there were volunteers who knows everything. I said, well, the volunteer want to help me take care of the childhood cancer. I said, no, you can do this for me. You can't take care of the patients, it's too complicated. So they did to fulfill his wish, and we found out a lot of people want to help this family with this specific wish. So therefore, this first one leads to other wishes for other children. This child want to be a cook, we want to be a chef someday, but he has neuroblastoma. I think because it was relapsed, we know that his time is limited. So this celebrated chef heard of this news. He said, well, come, I give him a special course. Yeah. So another friend who also likes to do the chef thing, went to his special session just for them. He even gives certificate for them. And then, and they were all happy. Of course, they all died a year later, but fulfilled. Both the child themselves, the family, and everyone who is involved. So we have found a solution that maybe fulfilling wish is a neat way of introducing palliative care for children. You see, you cannot offer. You want palliative care or treatment? Nobody wants palliative care that way. But if you offer them this way, fulfilling wish, then the child will say what they want to do. And we can help community to help with this. And for adolescents, they may have some particular wish, like she knows this TV star, she requested that she visited her. And some of the stars were kind enough, they went to visit her at home, which is all of us were unexpected. But we know that the community wants to help in this issue. After that, then we say, okay, we have so many children, what they wanted to do. Many of them, though, would like to go to the beach. So therefore, we make it a camp of people who want to go to the beach. And this way, they are gathered together. Mom also comes, and they all share together their experiences, like a group support. And the children were having fun. The volunteer helps distract the children from their mother and treat them as normal children. So this way they enhance quality of life. And what they do is simple. Just let the sick children be normal children. And everyone was so happy. And the volunteer get to know that, okay, well, they don't look like sick children at all. So in this way, we have tried many different kind of camps for the children and involve the monks in the process because everybody wants to do good deeds in Thailand. So this is part of their work. But all in all, what we do want to introduce palliative care so that we can take care of them at home. It started with fulfilling wish, and then we did home visits, and then eventually they stay home until the time comes. So you can see here, the home death is actually very warm, and everyone can do the spiritual stuff at home, which is meaningful for children and their family. So in this way, we have found that instead of trying to, when the child has relapsed, we can introduce this right away. Everybody was satisfied with the work and keep them at home, cared by community, and prevent them from getting more and more treatment, which is always fails. So we work with this 20 others treatment center in Thailand. So in conclusion, I would say palliative care is maybe not what you think. Palliative care at life to years, not at years to life. Palliative care is actually about living. This is not about, we don't really focus on dying. And that we involve the family and community. And that's much more from the healthcare system. And when introduced early, they lead to better quality of life. Thank you very much for your listening. Okay, I have like to now shift the perspective to digital health. And Dr. Wycliffe Weweru from PSI Global, Kenya, will share with us his digital tools and data system that empowers communities. Dr. Weweru.
We've been sitting for about an hour, right? Can I just ask us to stand for 1 minute? Just stand, stretch, take your hands as high as you can go. Try and touch your toes if it's possible. A little to the side. It's actually possible. Yes. Great, and have a seat now. Thank you. Earlier there was something running, just encouraging us to move and be healthy. So I was hoping that would help. So I'll be speaking about digital and what we at PSI have been doing in the digital space. And PSI, Population Services International, is a non-profit. We work in about 40 countries around the world. And our focus is working both with public and private sector, and as well as local communities to help people meet their health needs. And we do this in 3 primary ways. We work with consumers, individuals and communities to get them more involved in taking healthy actions for their lives. On the market side, we help grow markets for new products, whether they are, for example, lenacapavir for HIV prevention, or underused products and services. So trying to get people more access to the things they need for their health. And finally, with health systems, we work on helping to build resilient health systems. I'll start our digital work with communities first by focusing on paper, right? At the heart of a lot of the health systems in the 24 countries in Africa where we work, we also do some work in Latin America and the Caribbean and in some countries in Asia. A lot of the heart at the front line of that work are community health workers. And this picture is very familiar to many of us, right? When community health workers are seeking to provide health information or create demand for services, they typically walk around with these books, these printed job aids that they use to communicate, about health. And in Ethiopia, we have a project that's still ongoing that was trying to get adolescent girls to begin to use contraception. And often the conversation begins with the contraception itself, right? But what we did is, through a human-centered design approach, sat down with the girls and their partners and figured out what really matters in your life, right? What are you looking forward to? And a huge concern they had was, I would like to be successful in future. I'd like financial success, and we began to use that finance goal as an entry point into helping them plan for their future and then introduce contraception. And that worked, right? We saw an increase in uptake of contraception. But we chose to take that a step further and ask ourselves, how do we do this in a way that's interactive? And what we developed was an application that the community health worker would use. Now, you recognize that a lot of the places we're working in Ethiopia, in rural Ethiopia, with adolescent girls who do not have access to technology. So equity is an issue there. But a lot of programs that are bringing technology in the health of community health workers, into the hands of community health workers, focus on a phone or a tablet to just collect data, right? We said, why don't we use this device the other way around, put it in the hands of the girl, and she can actually interact with the content. And through that, we've been able to see an increase in the uptake of services just because they're engaging more with the content. What do you do if you don't have a community health worker? In Vietnam, we partnered with Babylon Health to bring forward a symptom checker that's powered by AI. Why a symptom checker? Because we all do this, right? When you have symptoms, at least we used to do it. The first thing you do is type in Google what your symptoms are. And, you find out that you have cancer. It doesn't matter what the symptom is. It was always cancer and you're about to die. But we thought, why don't we then just help you, make it a little easier by, again, it has an AI logic to it that helps narrow down to what your symptoms might be. But the idea was not just to pass you the information, but to connect you then to health facilities that could then provide you with the care that you need, so that you're not just sitting at home thinking, okay, yes, I'm going to die. But there's actually a connection to a health facility around you that you can go and see. And that really helped that signposting people into healthcare has helped. During COVID, we worked with the government of Kenya to help set up a chatbot for them. And the backstory is we received funding as an organization to help set up a chatbot for our programs. And we said, look, we have done this before, right? Where we as a project set up this tool that at the end of the project, we will try and hand over to government. And to be honest, that approach does not work, right? And so we said, instead of trying to do this ourselves, why don't we work with government? It's going to take longer than we think it should. But the beauty about doing it that way is that it was actually a very sustainable approach. And so we helped set up a WhatsApp chatbot that, while our initial funding was for COVID, we set it up in a way that, it takes as many topics, health topics, as government would like to communicate, the ministry would like to communicate to people with. And we saw rapid uptake of that. And you'd ask, why WhatsApp, right? Why didn't we create an app? And it really is that simple idea that, about 20 million people on Kenya on WhatsApp. No one needs to train them how to message, right? It's already you're spending a lot of time on your phone every day. So why don't we find the people where they are? And we found out to be useful. The challenge with WhatsApp or with structured chatbots is that they're not very engaging or interactive. It's menu driven and the content is very structured. And yes, it's effective at passing the communication, but it's not very engaging. And so in 2022, generative AI came into play, and we have begun to partnering with an organization called Odere, who are actually in the room, began to test, and we are in the process of, we tested and we have built out an AI-powered chatbot, right, that focus is on providing support to people living with HIV, with information for HIV, for TB, and other health needs. And the idea is that we are not just, the AI is tethered to a knowledge base that has quality assured information from the Department of Health in South Africa, from WHO guidelines. So it's not just answering questions from the internet, but it's answering questions based on quality assured information. And so that's why we are sure that, it provides that information is quality assured, is accurate, and that's really important to us because we're dealing with the health of people. But the second thing it's been trained to do is to be empathetic. And it's based off a project that preceded it that worked at providing empathetic care for men living with HIV. And that was a real insight in how the tone that it uses needs to speak to people's needs in a non-judgmental way. And the third thing it does is it's now providing behavioral nudges so that they can begin to adopt healthier habits. The AI does not run by itself. There is human oversight to it that provide guardrails, especially when a user needs to connect to an individual, to a human. They have that option. But it also has a safety mechanism that is looking for potential self-harm or an acute need the individual might have, and it flags that to a member of their care team so that it's, there is a measure of, a guardrail of security around that child. You can see a bit on the screenshot there, the thing that I spoke about tone. When you start engaging with it, you have a choice on what's the persona I want it to take, right? Do I want it to take an younger or older man or woman? And they each have a different tone depending on what vibe you're feeling on that day. And it's really showing great promise. We've been running it for about 5 months now. And it's, uptake has really gone up. We're working closely with the National Department of Health in South Africa, and that's working really well for us. Finally, you'll begin to hear conversations, in the digital space about digital public infrastructure for health or health ecosystems. The challenge that has been in the digital space in health around information systems is we built them off parallel or siloed systems, right? And there's a huge effort now in connecting all these information systems into one digital ecosystem. And I think it's a really great idea. Countries like Rwanda, I know Thailand are doing that here, Kenya, Nigeria, Sri Lanka are on this path of pulling all your health data, all the health data into one space, say, for example, into a shared health record. So at the bottom is, all the provider-facing applications, and at the back is the back end that you see. But the part that's missing is that engagement with the community. All the tools that are being described here focus on the health workforce, but not on community. And so we see that there's a need as countries are developing these digital health ecosystems to integrate health information that enables the health system to engage with communities and with individuals, and not just in a one-way approach, but actually bidirectionally, so they can begin to gather insights and feedback on the health system from communities. Thank you.
Thank you. Thank you very much, Dr. Wycliffe, for sharing us the role of digital health. And the last speaker of this session is that Dr. Kiyama. Oh, hold on. Let me see. Dr. Amy Kiyota. She is the environmental gerontologist from the National University of Singapore. She will be sharing with us designing a supportive environment for healthy aging. Thank you very much.
Thank you so much. I'm not a clinician, so I would like to speak about the role of environment today. I actually like to share a small story. It's that when I was in the graduate school, I read a book. It's written by Claire Cooper Marcus at University of California, Berkeley. Her book is called House of Symbol of Yourself. To me, since then, when I look at the environment, it always see that as a symbol of yourself. When you go to museum, you feel creative. When you're in a place like this, with many clinicians, I feel good and honored. But if it's not so great environment, that also frame who you are. And I think that's something that we have to be very mindful when we design for a space for older populations. So when I was asked to speak about at this conference, I decided maybe I'm just going to look at how people from the health perspective actually look at the role of environment. So this shows the contribution, what contributes to health from the social determinant of health perspective. I'm grateful to see 10% at least is a physical environment in this framework. But from a design point of view, I see design and built environment for every single list in this. We design healthcare. We actually create the environment to nudge certain behaviors. And we designed spaces to try to bring equity into a public space by creating a public space in a certain neighborhood. So today I will actually like to invite you into the way we think about from design point of view. I've been spending about 25 to 30 years designing space for older populations. Do I have good ideas about how to adjust this demographic shift with the design? I don't have a very clear answer. So I will actually like to invite you moving forward to really think together from here. And maybe I can actually show you some of my experience. So my experience of design actually is very similar to Maslow's needs, hierarchy of needs. When you look at these 5 levels, physiological and safety issues are something we are very good with designing. When you look at nursing home, when we look at hospital, they are very safe. Physiological needs are met. Yet, what is love, what is self-esteem, and what is self-actualization means? Because I hear a lot about loneliness. Do you think accessible environment will solve the loneliness problem? I will have to say no. Then we have to think about what can we do to design for purpose and meaning that is going to address the issue of loneliness. So I'll take you to a little journey. So the physiological and safety part to love and belongings. This was the nursing home I actually studied when I was in graduate school. Very institutional. And then at 1990, there was a movement for person-centered care environment. It is a little bit more home-like environment. That's the way I see how to move away from physiological safety response to love and belongings. These days, the place that I go and feel good about, it's just going to sense of belongings. The community integration to me, speaks to me as a sense of belongings. This is in Japan. The community integration is happening. So it used to be we segregated older people, children, community, school. They're actually putting everything together into a little, into one space. And also the divisions are glass. So it's not very much, divided. And they have farmers market in here. They have restaurants that is actually prepared by a developmental disability community. And they have public baths. And they also have a little food bath. So that people can actually come and share, and regardless of their age group. Another one that I see the trend is intergenerational bondings. And how I will actually like you to see how the environment look like. This has, I'll give you this. This place is one place. It used to be a supermarket. They renovated into elder care, so-called space, but they have 5 functions. Elder care, so the people who, group homes that a lot of people with people with dementia lives. And also they have daycare center for older person and daycare center for children. And they have restaurant, they have laundry. And those children are not residents, they are neighbors' children. Because this place is designed for everyone. And children don't have to actually talk to older people. They just show up and play. And that really makes it normal place. To me, this is a very good learning to me, because sometimes when you think about intergenerational bonding, people will say, okay, children, older people, you look at each other and talk, right? That does not going to first create the relationship, and second, people won't show up next time. So it's very important to have like a simple design strategies, like tons of seating space. And it's, easy to look inside, but if you don't feel like go inside, you can actually look in to be a part of it. And different function, that means that its place is normalized. It's not only for older populations. And self-actualization part, I start to see empowerment and inclusion. Why it's important? I actually love this picture. I took this picture. I've been working on the community development, which I will share. So basically, what we have done after the post-disaster area, we go in and help older person to create their own community hub. It's owned by the older population, run by older population for younger children, because that's what older people want. And I just really love this photo because, societal change is happening. We created this exercise bar for high school children, right? And the benches for older population. When we started, older people, this person is 83 years old at this moment. And those 3 kids are 16. And they were sitting in the bench playing video games. But, this makes you laugh, but at the same time, this is actually a reality. But I don't think our social policy is really embracing this. And also that designing is, it's behind time. So based on my learning of designing and also doing research, I actually learned the differences between placemaking and culture making. Somehow placemaking didn't sit well for me. Because this is a place where, so when we went to Japan, Philippines, Nepal, Singapore are the 4 places I worked for, we all created the place together with older population. Yet this, the picture between left and right, it's the same place, but it makes a huge difference. And there are certain places didn't go well. And, space is still there, but not many people there. And I always just think back and why it was. So the space and shared value actually create the place. So when we do placemaking, that's what we are trying to do. But what we are really trying to do is to empower older person to take ownership. So we need to actually have expected behaviors and experience with people. Sometimes we settle with a placemaking and they say, okay, we created this public space or, just space where we created with the community members. And then you go back, there's nothing is happening because we don't put expected behaviors and value to it. So which means that we really need to invest people. We have to invest educating people to really learn about what shared behavior look like. Let's say when you go to church, you feel the certain sense of behaviors that you have to follow because the space imposes you. So the same way, when we are thinking about just community hub run by older people, when you go there, you don't expect someone to teach you Tai Chi. You basically teach children how to read and, just really shifting the way of thinking. So the shared value that we worked on, I started to develop 2011 after the earthquake happens and tsunami happens. We decided to help them out. So we went there. And the older people wanted to actually do something back rather than being helped. So we created the shared value. Older people are valuable assets to the community rather than being helped. Life experience and wisdom benefit younger generation. and help strengthen the resiliency of their community. That was a shared value by older person. And we had a set of experience, behavior, and a set of behavior and the experience that we shared. This is the principle. I don't have a long, much time, so I can just, if you're interested, I'm happy to share with you. But these are the 8 sets of principles that we collect together. And so this is what we're trying to do. And then create the space. Basically, we create a space with people because space is just a space. The space becomes place when you have people. So the key design policy consideration is just basically design adaptable space rather than not so restricted. Elder-led initiative empower older adults to create together, and co-creation with older people from the beginning, and shared ownership with space among the community members. The last one is collaboration. We involve everybody, including community members to the stakeholders. So the policy recommendation is to create yohaku. It is a Japanese word. It's a blank area. We believe that when we over-design, we don't have a space for community to come in to make it perfect. I think we have a tendency to over-design with an attitude we know better. But we have to really intentionally leave the blank area margin to be able to include older person. So I would like to end with a quote that I found in Bhutan when I was working on the senior housing project in Bhutan. The time to be happy is now. The place to be happy is here. The way to be happy is to make other people happy. To me, it is a very important reminder that, we don't do things for the older population. We want them to have the opportunity to help us so that they feel happier. Thank you.
Thank you, all the speakers, for their rich and inspiring lectures, sharing. Now, what we have heard clearly today is that supportive environments are not created by health system alone. They emerge from the relationships, trust, design, and policy, and community participation. I would like now to move us on to a moderated panel discussion, where we can reflect on all these perspectives and explore the common threads. Yeah. And so to start with, I'd like to ask the panel, maybe anyone can chip in, that we have heard about models where each one of us in each area they have created, and just in general question of how can we move from a disease-specific focus system towards more relational and context-sensitive approach without burdening family and the communities. Yeah. Anyway.
Well, thank you. But I think same topic, and there was so much perspectives shared. We heard from you on family medicine, on adolescence, from you something very wishful, fulfilling the wishes, right? And amazing digital and then built spaces. I'm sure a lot of wisdom lies on the audience also, which must hear from them their views. But just to say that absolutely disease-specific models will stay in a clinical practice, but we must move towards a community anchoring. I think the first and the foremost lesson is let's stop treating community as a beneficiary. In fact, community anchored projects are something which are sustainable and which will go much larger and have a more deep impact, especially in the relevance of public health. We talk about early childhood or old age. If it's not anchored in community, if community is not involved, they will not be sustainable. And the same lies for even digital technologies and all. Technology should not be seen just from a prism of technology, but it should be seen from a prism of policy. I think I love when you say that, there are different apps there, but the apps are not speaking to each other because the connecting policy is missing, the interoperability is missing. So we do talk about platform, but networking is missing. And this is where, organizations like PMAC hold a great promise for us. The idea is to go back to community, respect community. A lot of wisdom lies in community, actually, right? From child rearing to practices which were traditionally done there, but perhaps have been eclipsed in the name of modern medicine being there. So I think going back to the roots, right, from the built-in environment or to even digital technologies, which should be more simpler and reducing the burden of the frontline worker. I'll give you an example that I've worked from in a state in India, and we see that the digital health, the worker is doing both physical forms, and then they should put the same form in the online format and then send it in the PDF form. So that's a waste of time and duplication of efforts. I think technology needs to empower people and make it more simplistic and available. But the anchoring is at the community level and the family level. Thank you.
Yeah, is this on? I would totally agree. I mean, I think for the sort of change that we are trying to make within the hospital, which is the community, it has really grown organically by starting the conversations between the whole multidisciplinary team. So teaching together, having those conversations with a sort of flat hierarchy has really helped to sort of change a culture across the board, or beginning to change a culture.
Right. Would you like to say something?
I'm happy to comment as well. I think for us, what we're experiencing, certainly in the delivery of family medicine and primary care, is the elements of clinical disease management, which will always be present, but the understanding more and more that we are seeing the relevance of social prescribing and the integration with community as part of the prescription for good health. And we know that we can't do those two pieces in isolation. And we increasingly are seeing that our patients are so much more successful and are truly feeling the progress and the ownership of their own good health when we engage very closely between what's happening in the clinical space and what's happening in the community.
Yes. From the Asian perspective, I believe a community would like to be involved. There was many people who want to volunteer for a lot of things, but they don't have the place to volunteer. And in fact, if we can harness, the spirit and I mean, a lot of people have free time. A lot of people don't have are already well finished with their work. They want to volunteer, so they don't feel as a burden. Actually, they'll be so happy if we can involve these volunteers in doing the work. So there's a lot of potential. It's just that the clinicians need to look outside their working and allow that to happen. And we speak to many volunteers. They want to come to the hospital, but the hospital says, no, if the volunteer comes, there's a lot of work for us. We want to ensure the safety, and that it creates more work, actually. So the best way is to take the care to the community. There's no regulations there, and people were closer to their workspace, to their home, so that the participation is potentially much more. And I'm sure everybody will be happy, but it takes some courage for the clinicians to think outside the box that way. Yes.
Yeah, and I think as you're speaking, we need to recognize that we all practice self-care, right? When you fall sick, that period as you're trying to figure out how serious is it, there's a lot of self-care we are practicing that often doesn't show up in the formal health sector. And I think digital tools can play a role in helping us get better or better quality assured self-care that then can help you triage into into the formal health system should you need to. So just tying that link between, digital can play a role in the link between community and health facility.
All right.
I think from architecture point of view, I always go back to the definition of health in WHO's definition of health. It says state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. I think we probably want to be mindful that health is not about healthcare, and I think the community actually do play the role to me. But I will actually like to point out one thing. I work a lot with community members. We think that older people has a lot of time. It's completely different from my experience. Older people are very busy, actually. And also a lot of people would like to make some income. So yeah, we have a tendency to think that older people have time and they don't really need income. That probably is a part of demographic shift that we probably have to shift our mindset as well.
Thank you so much for your perspective. Yes, as we all seen the models, and we were thinking how to scale up to the more inclusive of other communities. In scaling up intervention, whether it's a digital governance, reforms or design solution, how can we ensure that the equity and the dignity and the cultural relevance is there at the central of the design? What do you think?
I think that's a disadvantage sitting next to you. But I think very well said. Contexts are so important and they should be given due importance, not only in the built spaces, but even in the behavior terms, in the nutrition diversity, if we talk about. We have a habit in public policy to do a top-up approach and saying this one straight jacket approach across the province or a country or a city and all. But I think we need to give space to the customization which follows. Simple things like food diversity, nutrition diversity would be very different from different areas, and what are the local crops grown there. They should be given to either child or an adult or whosoever it requires them. So those are the fundamental points on diversity. I think it's very important that the multi-sectoral approach is being followed. And it's difficult. It's not easy, I must say that. Multi-sectoral approaches are difficult, but it's important to get the whole of government approach, starting from the community, family, but then different departments which come across also supporting them. That will help us making programs, projects which are sustainable and impactful, rooted in the community. Then only we will be able to take them to scale. So for taking anything to scale, one, it has to be evidence-based. Now I just wanted to tell you something, like when we're talking about role of community, there needs to be some guardrails also, because you have seen in somewhere in the villages people giving steroids without any reason and they're not qualified practitioners. So I think it's important that there is some kind of certification and accreditation, capacity building within the community, and that's important. This should come within the community. And I give you an example. When we are building daycare centers in a state in Meghalaya, we give them the supplies, but the labor mustn't come from the local people, because then they are trained, they get ability to make them, and they also have remuneration from them. Similarly, the governance comes from the local self-government or the local self-councils there. They get ownership and they get responsibility. And then you also have a medium of putting their corporate social responsibility money. So I totally agree that it's perhaps also not that we don't have volunteers or we don't have people who want to do some altruistic work, but the medium is very difficult. The trust is not there within the society. How to engage them, the via media is not there. So I think it's important where the projects get anchored in community, they will be more sustainable and long term.
Yeah, I totally agree. Actually, I was just sitting here thinking about how our project has sort of scaled up, and it really has done that organically. So we started in paediatrics, but actually it has now gone sort of trust-wide to the adult services, because I think the community is involved in sort of showing to the rest of the hospital how this is really working and how they're managing these young people more effectively. Everybody seems happier because they've got the confidence and the skills to do that work. And so we've had our adult equivalents sort of looking down, sort of thinking, oh, we need that in adult services. So now we're all talking to each other. So the other thing is about communication. And all talking about this together. I mentioned when I was talking about understanding the landscape, I think we didn't know what we didn't know. And so communicating, understanding, and then it sort of organically happens from the community being involved.
Well, I myself have also, interestingly, started with pediatrics, but then moved on to adult world, whereby palliative care in adults in the community actually does not exist. Yeah, at least they were thinking there were services where people were incurable in the hospital, some sent home to be taken care, but the need for the people, elder people, is much more than children. Like older people die 200 times more than children, and who takes care of them in the way that we have discovered in pediatric oncology. So adult cancer patients, especially in Thailand, where death is actually realized that it's natural for the Buddhist-based country like Thailand. People wanted palliative care rather than keep fighting and it's not curable. People want to make peace. They want to live with cancer in peace. Yeah. But there was no provider for the care for that. So I have realized that, okay, well, I try to sell my ideas to adult colleagues, but they were all busy. They didn't have time because adult cancer is like 200 times more cases than children, and there were less of the oncologists per patient. So they didn't really have time. So we take the lead and we offer the home-based palliative care for adults. And we found out that the nature is different. Yeah, different being that actually reverse. Like adults, their children want treatment for their mothers, but the elderly, the mothers and the fathers said, "No, I didn't want it. I want to live in peace and no suffering. That's all." So and the adults have lived their life fully already. So if it takes too much, of the suffering in order to live longer, they said no. So we have taken the solution of home-based palliative care for them, and then the model is different because they have finished already. They didn't have wish fulfilling thing, They just want to live in peace at their home. That's all. And so we have found solution that instead of relying on the government or somebody to support, people have they wanted to do this because it will save cost. Yeah, choose palliative care, save much more cost. If you get treatment, they need more cost. Yeah, so this solution, people were willing to support the work by themselves, and we have found this as a social enterprise, as a solution for Thailand, for example.
As a medical student, in third year we have community medicine. I think in India we follow the British system of medicine. There's a J. Park's book on community medicine, and the first prologue starts that health is not the custody of doctors, it's the community. It took me 10-15 years to understand that term now. That actually it's the community which empowers everyone to get this, and how it beautifully embodies what we do in the field. But of course, we all became physicians, but I still realize that how powerful a community is. And today's work, which each one of us are doing, actually this signifies that how community has the most wisdom. And if we go back to them, we get the best results out of it.
Wonderful.
I might build on that actually, because I'm reflecting on the education and training side of things, and considering for myself how important it's been in our faculty and in our department to increasingly see the role of our patient partners
not just in the community environment clinically, where patients are part of the encounter for our trainees, but actually seeing patient partners as advisors and working with, in our case, the patient faculty advisory committee in our department, and in a formal role with recognition of the role, with a governance of their own, with the process of being recognized by all the other faculty in the department for their presence. And I think not only through the educational tiers of training are there opportunities for lived experience with patients, but also to see it from the perspective of how our institutions are training from the faculty and the chairs level down, because there's a place for our patient voices to be really heard and to be formalized. So not necessarily just the informal experience of engagement, but to have a formal presence, which I think actually shapes, again, that concept of community and culture right from the very beginning.
Sure. You have anything to add? Please.
Yes, I think I'm coming from a community development perspective. I think when we scale, I think the design means two meanings. One is a verb, one is noun. I think if we were to focus on the noun part of outcome of design, normally those are very difficult to scale in a different culture. But principle and methodology and educations, when you're breaking it down into more principle level, I think it is more scalable. And also that this is where the research comes in. I think if we were to design from the beginning to evaluate the community setting, that will probably be very effective way to also properly scale. The last part is that sometimes we try to scale one project, it fails. It always fails for me. You always have to think about ecosystem around the project, the people and the community members and the organizations.
Okay. All right. Did you add anything or no? Okay. Well, that's great. Thank you very much, everyone, for this reflection. And now I'd like to open the floor to the audience. And then please feel free to share your questions or comments or experiences. And then particularly, for example, from your communities or the countries. Please go ahead.
Really great panel. Just fantastic group of folks. The ladies, you did so well. Dr. Janakiram, I just want to say the Wheel of Privilege, amazing, absolutely amazing. So a question built on that. How do you, and this is kind of for everyone across the board, and I'll use an example from Dr. Waru's presentation on Kojumpilo as well. How do you rationalize areas where you've got government representatives and stakeholders who are all at the center of that wheel, and community members who are scattered at the edges of the wheel? And throughout this conference and every health conference, it's always integrate into government systems and bring community and government together. How do you rationalize those areas where government and community are at odds? And I'll use two different examples from the sexual health HIV space. In Zimbabwe, if female sex workers want to get treatment, they have to bring a male partner to the clinic with them. In South Africa, there are test and track and trace programs where people living with HIV feel like they're being hunted by the government. And so, how do you guys, in the work that you do, think about that? Think about the wheel of privilege and how there's that difference and bringing government and community together.
That's
easy
a fabulous question. I suspect we can all probably respond to some degree. I will add that I think that when we're in clinical practice, we have a really remarkable privilege of being able to actually serve everyone on that wheel of privilege and power. There are very few spaces where, I suspect where someone necessarily interacts with those right at the center of power and those on the margins. And certainly in family medicine, we have many, many opportunities to do that every day. I think because we do that, I think we also then have an opportunity, as much of our work is based in community and community informed, to reflect solely on what we're seeing and what we're hearing. So if we have patients who are inevitably on the margins, and we have government or policymakers who tend to maybe be more in the center, I think we have a unique voice. We have an opportunity in family medicine to shine light on maybe the voices of our patients who may or may not have the opportunity to be heard otherwise. And in fact, we know that many, many times, more often than not, even our voices are heard more clearly when we're actually shining light on the voices of our patients. And I can think of a really clear example right now in the Canadian context, which is that we've recently had incredible surveys across Canada that are speaking to what patients are asking for from their governments and from their provincial bodies and federal bodies. And that kind of capturing of patient voice and patient data, even though one might argue that many of them are on the periphery, is being heard. And it's being heard because we're channeling it through the avenues of a collective interest in good health and well-being. And I would actually say that because we're in family medicine, we have perhaps a really unique opportunity to be good listeners to that and maybe channel those voices upward and onward. They don't even need to be our voices. They need to be the voices of our patients.
And just picking up from there, one of the things we do, I mentioned this in the presentation, is user-centered design. And what that really means is we bring the consumer, the person who's designing the program, all the stakeholders into a room and focus on helping everyone else gain empathy, really walk a mile in the shoes of this consumer before you generate the insights that will help you with the design. Because often you'll find that, we are all well-intentioned, but we don't really understand what the needs of that individual are. And until we get to understand their needs, we won't really understand their perspective, right? And so that's an approach that we have found works for us, not just on the digital side, but across the programs that we design, that the moment you gather, you have empathy, then it becomes really clear on what do you need to do to support these individuals on their health journey.
It's a brilliant question. And actually, so when I sort of started on this mental health work, one of the real frustrations was that the sort of management was saying that these patients block beds, they're in the hospital for ages, they're causing a lot of problems, find a solution to kind of either not admit them or get them out, which is just terrible because, these are people, these are patients. And what we really needed to do was find, care that works for them. If they need to stay in hospital, find sort of therapeutic input rather than them just sort of sitting in a bed. So it sort of came back to really using patient stories to explain to the managers that actually, that they're not blocking beds, but we need to change. We need to change our culture and how we are looking after them, perceiving them, and what can we actually do to make the most of their stay. We're not the right place for them to be, but nowhere really is at that point in time. But we're a safe place, and we're a place where we can look after them and give them the care that they really deserve and need.
From my perspective, I may have a different answer, and this Thai government, Asian government, are not so stable, and actually they have unreasonable rules. So we would rather develop something that have tested the model where we don't depend on the government. We are free to decide whatever works for the community, and that the community will support us. We have proven that these things actually works, so that we didn't have to submit to the unreasonable rules that government requires. So we are pretty much free to design anything that is useful and the community benefits and support us independently.
Can I? I think what we I work with the older population, so their stigma is not that high, but we still deal with ageism. I think what we encounter are two ageism issues. One, that we don't have a strong trust for older people to be able to do things. Another one is older people themselves. They feel like they're too old to do something. To get over this, we've learned that many years of practice. If we ask older person to take a mentorship role, or like if they were to be the one to help others, they will step up. But if we were to ask them if we can help them, they are very reluctant. I think because of the ageism issues behind it.
Well, let me give an example, since I'm one of the health administrators and all. So we have a policy that a village of 1,000 will have a daycare center. Now, what about villages which have 700 population, 600 population? So they become your fringes, right? What you're talking about. How will they be heard? I think we need to find an innovative solution. The innovative solution we found out was that one of the mother's house was made as a community kitchen. She was given incentives, and then that house was converted into a daycare center with their community anchorship. So sometimes you do come out on those fringes, but you need to come up with innovative solutions to see. You need to be more sensitive and empathetic to see solutions to those.
All right, thank you so much. I think we run out of time, so we have come to the end of the discussion. I'd like to thank our panelists and the audience for such an engaging and thoughtful discussion. So today's conversation reminds us that the demographic changes, not only the challenge, is also the opportunity to review the systems, whereby we can evolve community to become a more compassionate, inclusive, and human-centered. So I'd like now to invite our session co-lead to share the closing reflections and the key takeaways.
Thank you, Dr. Isarang. My name is Nat. I'm a pediatrician at Chulalongkorn University. I think the panel today was absolutely amazing. Just wealth of knowledge and experience. And I think if there's one word that came to my mind listening to all of the talks was people-centered, person-centered, and putting people and relationships and activities at the center of everything. And I think definitely with Dr. Emmy, who talked about it being a place where activities happen is really the heart of what everything that was discussed today. So we're very grateful for the sharing of the variety of different mechanisms, how this can be achieved. And we're so grateful to all of you today. And I'd like the audience to join me in giving them a round of applause. And thank you for joining our session. So this is the end of the session.